Happy Heart Month. It's still February, and this is Dr. G at the Heart of Healthcare with bonus episode 39, talking about American Heart Month. And I have my co author here, Sharon Harris, the end of life
Hi.
doula of Serenity, and also a very special guest cardiologist, Dr. Colleen Fearon, MD. Hello.
Hello. Good afternoon. How everyone's doing today?
We're good. We're good. We got through, the Valentine's Day hearts. I made my heart here and we did, it's still Black History Month. So look at this beautiful panel we have here. So I'm
hmm
so excited to talk to everyone today and to just highlight heart disease. So let's just go ahead and start by letting our cardiologist just kind of give us a brief bio of yourself. Like, tell us how you became a cardiologist.
Hi, everyone. So my name is Dr. Farron, Colleen Farron, that is, and originally from Jamaica, then moved to Georgia for my education and ended up in California where I met these beautiful people, um, where I did my general internal medicine training and cardiology training, and now I'm out here in Kansas. So, the early days of cardiology was all in this kind of sounds really unique, but playing with the insects or creatures around that surrounded me outside and wanted to help them. So, uh,
Yeah.
so, so that's it. That's how I'm out here today.
Yeah, that's so awesome. And then, highlighting an HBCU, you did medical school at Morehouse, right?
Yes, Morehouse School of Medicine, class of
Oh,
2017.
oh,
Okay.
so exciting. Where you have a great resume and every one of my audience members knows that I believe the heart is the best organ. So we're so
It
delighted to
is.
have you here.
It is.
Yeah, yes, it is. So, Sharon, you have anything to say before we jump in?
No, just happy to be back.
Hey,
Hello,
hey.
everyone, again.
Yes. So it's American Heart Month. February 2nd, we had Wear Red Day for women's cardiovascular disease. Um, the American Heart Association even created social media to highlight Usher's song was helping, with CPR. We had Damar Hamlin, and the initiative about that. So a lot of the focus was on prevention, risk reduction, stop smoking, checking your cholesterol, your high blood pressure, diet and exercise, and reducing stress. But there's not much talk about the end stages of heart disease. So that's what I wanted to talk about today, since I believe hospice is the heart of healthcare, and many people don't know about the end stages of it. So I hope this show is going to help enlighten everybody about that, because it affects everyone at some point in time, even pregnant women who may suffer from preeclampsia. The American Heart Association also highlighted a post about that, and we also know that women, when they're pregnant, they're at risk for a lot of things, with the increased blood volume. And so we're so grateful to have our expert here to talk about it. So I wanted to mention a patient I had back when I was a palliative care medical director in the community. Um, I remember a lady was having a heart failure exacerbation, and she needed to make a critical decision of, do you want to continue on your palliative road and go to the hospital for this exacerbation, or do you want to go on the hospice care? And she was adamant about not being hospitalized again. But I said, well, what is it going to take for you to make that decision? And she said, I want to talk to my cardiologist because I trust that cardiologist the most. And so that's why I like to bring in experts, because you're taking care of patients for so long, and we're strangers when we just show up at the end stages of the disease. So I'm hoping that we can bridge that road and have a continuum of care for patients. So, any thoughts on that, Dr. Farron?
Yes. So there is a lot of misconception or failure to diagnose when patients do have heart failure, especially patients who do not present and follow up with their doctors regularly. And so sometimes they're like, oh, okay, I'll be better maybe tomorrow. And when it comes to the final stages, that's when they present to their primary care doctor. So in regards to heart failure, there's multiple definitions in regards to the stages. So yeah, stage A through D, and specifically, we're going to talk about stage D for the patients with advanced heart failure. So stage A are the patients who are at risk for heart failure. That means that they have their past medical history or their medical history, they're being treated for a high blood pressure, hypertension, or cholesterol problems, atherosclerotic disease. They have diabetes or metabolic syndrome, with obesity, or maybe they're drug users such as meth, heavy alcohol use. These patients are at risk. And so a lot of patients who are at risk, they do not realize the effects of their hobbies or their habits to down the line having these issues. And so, over time, your heart function starts to change, the structure of your heart starts to change, and it's not able to manage put in power, because the heart is the pump of the body. It can't manage supplying the body in regards to for its daily functions. And so that would be considered stage B when they have some structural changes. And then when you start having symptoms, that's stage C. And that's definitely where you want to start giving goal-directed medical therapy, try to address the changes of the heart, trying to change the structural anatomy of the heart to try to have the patient in a sense recover before they end up to advanced heart failure. And that is stage D, which we want to discuss, because advanced heart failure is a patient who has a lot of symptoms. They have shortness of breath, they're unable to lay flat while they're sleeping at night, they're sometimes they're experiencing chest pains, or sometimes their rhythm is out of control with increased arrhythmia. And so these are the patients who have significant symptoms, and we are treating them with goal-directed medical therapy. These are heart failure therapies that has been shown to improve mortality, meaning that increased survival. So you have them on the optimum medication, and they're still experiencing symptoms. So these patients who are still experiencing symptoms, you have to start discussing, okay, do you want to increase survival? Should we refer you to a heart failure specialist so that they can evaluate you for different options? And so we know we're talking about palliative and hospice care, especially for the patient in the chapter we just previously discussed. But once you're at this diagnosis of advanced heart failure, you'd want to have palliative care on board, because you can chime in, Dr. G, at any time. The earlier is the better care in regards to patients, so they can understand what's going on in regards to their health.
I have a quick question. Can I ask a question? So once someone, let's say, before we get into this gentleman, because I imagine Mr. Paul in this chapter is about 70, 80 years old, but let's kind of rewind earlier into his life, maybe when he had the cabbage. Is that one of the options that you're talking about when people are referred to a heart failure specialist for their options? Is it, transplant? What are the options that you're referring to?
Okay, so say this patient, at the time of his cabbage, when he had the open heart surgery for his bypass, he has disease of the vessels of his heart. So that is the number one cause for heart failure, is patients who've had heart attack or had severe disease. And so at that point, they should have been monitoring, getting follow-ups with their cardiologist often, and being on appropriate therapy, especially if they had damage to their heart and they're symptomatic. So we have definitions, so I can answer your questions. I know this is elaborate, but we have definitions for patients who have severe dysfunction of the heart, and that's if their ejection fraction, how well the heart pumps, if it's pumping less than the 50%, because 50% is normal, but you're pumping at less than 30%. And then you are receiving the optimal therapy as we discussed before. And so in regards to the options, you have maybe you can bridge them with a left ventricular assist device. So this device is something that you implant in regards to your heart to help pump out the blood because your heart is too weak. Or you're someone who will be more dependent on medications through the IV. These are called inotropic medications. And a lot of people do not understand that once they're on this therapy for a long period of time, it also increases your risk for mortality, or I should say, increase your risk for death. And so another option is if once you're getting evaluated by a heart failure specialist, you'd want to consider if it's an option for heart transplant. And this is a good option if it's determined by this specialist. And where it ends up that, once you have a multi-care management group, and this is discussed, and if this is a good option for you, you need the extra support.
Well, I just want to interject this one little figure for our listeners. Also was highlighted by the American Heart Association. It says about 17,487 people in the United States have coronary heart disease. And this is the most common form of heart disease and can often be prevented. So that makes sense that their campaign was about that. But again, today we want to focus on, the end stages. And I thank you for giving us the definitions of the stages that are current, because in the guidelines for hospice, they focus on the NYHA classes, for 3 and 4. And so I'm glad we're able to correlate that with stage D as you're referring to. So unless you had something else, I want to go ahead and jump into Mr. Paul so people can kind of get a picture of what this story sounds like and some of the things that was experienced. Okay, so we'll just go ahead and jump into the case of Mr. Paul and the real deal about hospice care, chapter 4. So let's go ahead, Nurse Sharon.
Okay. So first, I'd just like to say that Mr. Paul was and always will be near and dear to my heart, as well as his family. As the bedside nurse, as the end-of-life doula, who is there present managing those end-of-life symptoms, it is always my honor. I'm happy to be there. I'm passionate about being there to educate and provide that support for that patient and that family.
And we're so grateful.
Yes. Well, thank you. Okay, so I'll go ahead and get started. So Mr. Paul had heart failure and had suffered 5 hospitalizations in 9 months, then signed on to routine home hospice care 4 weeks prior to his passing. Now, when I met the couple, they told me they had been married for 50 years and shared stories of what it took to have a good marriage. They called them pearls of wisdom. And again, I think this is just reflective of when you're there and when you're present, you kind of build this rapport and relationship, outside of your stated goals, which is to say, I think that's a good rapport and good solution or establishment that you have for those members there. And I always thought this relationship that they had was a perfect example of what true love looked like. So as Mr. Paul's disease progressed, he often found it difficult to breathe. As Dr. Farron mentioned, there was some difficulty, shortness of breath and things of that nature. He also experienced generalized pain, which led to some anxiety. Um, so Mr. Paul received a hospital bed, oxygen, medications from the hospice agency to ensure that he was comfortable and that comfort was maintained. Now, during the 4 weeks, Mr. and Mrs. Paul frequently expressed how they wish they had known about hospice care sooner, and maybe they could have enjoyed more time together at home during these past few months. So one night during a visit, I recognized that Mr. Paul's death was imminent, which Mrs. Paul understood and accepted what was happening due to continued education that I provided as I was bedside. So I had previously discussed with the couple about what to expect during our time together. I explained that I could not predict the exact time of death, but I knew in that moment that it wouldn't be much longer. So during my last night there with Mr. Paul, I was in constant communication with our medical director to manage the frequent adjustments to his medications while Mrs. Paul watched quietly from her bed. In the early part of the morning, Mr. Paul became very restless, yet it was not time for another dose of his medication. Sitting bedside, I took his hand in mine, leaned in close to his ear, and gave him reassurance. Mr. Paul eventually relaxed and fell into a deep sleep. Several hours later, Mr. Paul peacefully passed away. Mrs. Paul was also at peace and thanked me for being there. I was watching you all night, she said. I saw you when you prayed for him, and that helped to put his soul at rest. Thank you. You are our angel.
Yes, you are.
Mhm.
Yeah. And so, the story in this book just highlights the advantages of hospice care because people don't often know how it looks. And so the nurse is the quarterback of the team, and end of life doula, as Sharon of Serenity End of Life Doula is holding vigil there with the family and communicating with the medical director. That would be me. And so I then went into some of the advantages just to kind of break down what that is. And I'll go through quickly because Dr. Farron, you were already speaking about that. But it talked about people suffering from heart disease. They're eligible for hospice care when symptoms of disease have reached the NYHA Class of 3 or 4. This is when they have symptoms such as chest pain, angina, shortness of breath, lower extremity edema, and minimal exertion at rest. These are typically patients who have heart failure or some other type of end-stage heart disease. Given the common risk factors of hypertension, diabetes, obesity, cigarette smoking, etc., the number one cause of death in the United States is cardiovascular disease. Developments in healthcare have delayed death for many patients with its ability to open clogged coronary arteries. That's what Dr. Farron does, and perform surgeries like coronary artery bypass graft. That's what a cardiothoracic surgeon would do. And even place stents in those grafted vessels once they've done that. That happened to my father-in-law, which was unbelievable. Anyway, people are living longer due to these innovations, but at some point their hearts can become weak and they progress to something called congestive heart failure. Now, here I simplified it because we're trying to cut to the chase here. This book is a tool for patients and families, for end of life doulas, for death doulas, for caregivers, just to understand the concept. And we didn't want to get too technical, but we want them to know what's important. And so to finish up, it said the symptoms of CHF may cause people to be hospitalized for frequent exacerbations. They often need oxygen, diuretics to get fluids off, and guideline-directed therapy to help their heart function more efficiently. All of this can be treated at home with hospice care, and obviously at the end stages, once all the workups have been completed. The hospice physician can increase the medications before a CHF exacerbation occurs. Weekly home visits by a hospice nurse helps to manage symptoms along with the interdisciplinary team to assist with psychosocial issues. At the end stage of CHF, when people elect for hospice care, we are able to keep patients at home with their families rather than making repeated hospital visits. Mr. Paul should have known about hospice care sooner than the last 4 weeks of life. So that's our chapter 4. And let's kind of just chat about that.
I just want to add, just for patients, doctors all have this information, but sometimes there is a gap in regards to understanding for the patients in regards to their care. So I've mentioned before, recurrent hospitalizations in the past 12 months, repeated hospitalizations, emergency department visits for heart failure exacerbation, that increases your risk for mortality. And that's basically a clinical indicator that you do have advanced heart failure. The need to have intravenous inotropic therapy, like I was telling you before, you're becoming more dependent on these medications to keep you from feeling good, able to go about your activities of daily living in whatever capacity that may be, because you may be limited because of your symptoms, but to give you some help in general. As you've said before, persistent NYHA functional class 3 or 4 based on your symptoms. That's just defining how you're feeling. And this is how you're feeling at rest without activity. And then especially for patients who have severely reduced exercise capacity, you're unable to walk a block on level ground because you're short of breath or you're fatigued. Those are clinical indicators that you have advanced heart failure, especially when you're on appropriate therapy to improve your symptoms and they're not working. You're not tolerating the medications because your blood pressure is too low or your kidneys are worsening. And then also we've been escalating your diuretics at home and it just cannot maintain your volume status. You have to keep going to the hospital to get IV care. And so early intervention with palliative care, as you have mentioned, Dr. G, before, it's very, very helpful with getting all the information and keeping you with your family and decreasing the stress and able to have a better progress in regards to your care and your health. And sometimes people think, I'm sorry, one more thing.
No worries.
Sometimes people think palliative care means hospice, or they think that they're giving up in regards to trying to survive or live a longer life. And, that's what I think scares people a lot. But think of palliative care of more support and more information and being able to live a more comfortable life.
Thank you. Thank you. Cheers to that. Wow. So, a lot of these, the campaign was about hypertension and obesity and smoking. So, a lot of us, I know I'm carrying some extra weight right now. So a lot of us were really not thinking about, the effects going down the road. So I don't know, you have any words of encouragement for us? I know we did focus on the end of life, but any encouragement for prevention for us other Americans that are not at the end stages and maybe can do some more preventative care?
Right. So patients, like I've mentioned before, who are not controlling their blood pressure, they refuse to go to their doctor visits and check their blood pressure and be on the medications they're recommending. The amount of salt intake, that definitely affects your blood pressure and your cardiovascular health. You also have to think about diabetes. How are you taking your medications? Are you checking your A1C? Are you making sure that you're on top of everything? And then you have to think about weight loss. Are you exercising? Are you getting your heart rate up? Are you exercising at least 15 to 30 minutes 3 times a week? Get your heart up so you're able to increase your functional strength. So you have to think about these things when you're thinking about preventative medicine. Tobacco use. Tobacco use is a risk factor by itself for increasing your risk of myocardial coronary artery disease and increasing your risk for blockage of your coronary arteries. And so to prevent a heart attack, and then sometimes you just cannot prevent this because you're born this way. It's in your genes. Mm-hmm. So you have to think about all these things that you're including in your life. And a lot of people don't even realize that stress is also a factor as well. So if you need that therapy, if you need that one happy thing that makes you relaxed, you need to take the breather, you need to have that rest and sleep, all of these play an important role. Everything you do in life is important.
Thank you so much. That stress part, I think we really underestimate the effects of stress on our lives. So thank you for mentioning that. This has been so informative for us. Um, there's the hot topic of these GOP inhibitor drugs for obesity and diabetes right now. And I know some of them had benefits for heart failure. So I guess we just have a lot of tools and a lot of information here that can empower people to take control of their health, ahead of time and have more of a quality of life. So I'm so grateful that you were able to enlighten us on some of these things.
Yes, it's been my
Very good.
pleasure.
Can I ask a question of Dr. Farron?
Of
Of
course.
course you can.
Okay, so Dr. Farron, when you come across your patients who are at that end stage and you have to have that conversation with them, what does that look like for you?
First you want to understand what do they know? How do
Right.
they picture their health? And what are their goals? Is this something that they want to change or address? And I think they become very more in tune with their health when they just can't breathe to have their smoke
Mm-hmm.
or can't sleep because they have to sit up in the recliner. So I think the most important is where do they see themselves in their health? And so that's where I start off with and say, um, I'm not sure how much you already know, because sometimes patients they say, "Oh, my doctor never told me this." Oh, and you're the first person to tell me this, but they probably have heard the doctor say this before, but just not in the terms that they would understand. And so, what I like to do is to just talk to them and say, "Okay, let's have a chat." We're having our girl chat right now. We're having our guy chat right now. Let's have a chat. What do you think is going on with your heart? I had a patient the other day. He was pretty young. He's my age, in his 30s, early 30s. And, he had a diagnosis with severe heart failure, low EF about 10-15%. And that's because of his own doing in regards to alcohol intake, which a lot of people don't even realize with the heavy alcohol use, or just I'm young, happy, and free. We're not saying everyone who drinks alcohol is going to have heart failure, but everything needs to be done in moderation, or none at all. And so he was talking with him, he didn't really understand everything that was going on, but he understand that, okay, I need to stop drinking, which he did. And I need to follow up with the doctor more often, which he's doing. And so a lot of people won't have that same outlook in life, but as long as you're having a good conversation with them and seeing what they understand, and that where it becomes more ingrained in their brain and in their life, I think that's the best first step that you can take in regards to treating patients and not just blaming them for everything that's happened to them.
Wow.
It's great because that, just over my years and in my experience, I would come across those. And I always point the question back to them to have them tell me, what do they know about their disease? Are they aware of the trajectory? Are they aware of how it's going to progress? And, because it's difficult, and a lot of times, even my own mother included, she'll go to a doctor, they'll tell her something, and I'll come back and ask her, well, what happened? She doesn't know, oh, they told me this, but I don't know what they were talking about. And, so I see that a lot, specifically in our community. A lot of times their response is like, yes, yes, okay, okay, nodding the head, like they understand. So I just think also, again, it's in the way it's framed. Then when you kind of pivot it to their understanding, you can kind of get through and maybe get a little more education. So I think that's great.
Yeah. And sometimes I like to write little notes and say, you were diagnosed with heart failure.
Oh, wow.
Yeah.
So it's very straightforward.
Mm-hmm.
Wow. Well, thank you so much. I mean, I don't want to take up too much of your time, but I appreciate having a specialist here. Each chapter of this book, um, just is a body system, and I really value the specialists, and I really hope that more specialists can bridge that continuum of care with us at the end stages of life so that people again understand the trajectory of disease. So thank you so much for being here, Dr. Firan, and my co-author, Nurse Sharon. um, there you go. And
There
we
I
are
go.
gonna, there you go. And we're gonna sign out for February. I'm a year older, a year wiser. um, and we're just so grateful to be able to bring this content to the public so that you can have the best quality of life. So, signing out on episode 39 of Dr. Chi at the Heart of Healthcare, Heart Month. Peace. Thank you.
Thank you.